Hello, my name is Jonah Essers, and I'm a pediatric gastroenterologist at Swedish Medical Center. And I'm thrilled to join my colleague, Dr. Carly Osk, in this fall educational conference in discussing transitioning inflammatory bowel disease patients from child-centered care to adult-centered care. I'm going to start by providing the pediatric gastroenterologist perspective. I'd like to start by highlighting three important concepts that should help illustrate why it's important to have an action plan when transitioning pediatric patients to adult GIs. The first concept is that being a child with inflammatory bowel disease is a really lousy deal. There's a lot of evidence to show that children with IBD have a more severe disease course. Additionally, they tend to have more extensive disease throughout their GI tract. They usually require more potent medications as well as higher doses, and they often require surgery at a higher rate as compared to their adult matched peers. Additionally, having inflammatory bowel disease as a child is a threat to growth, development, and pubertal maturity. There is an increased risk of anxiety and depression in children with IBD as compared to children with other chronic illnesses. Also, children are still developing their maturity and their responsibility, so they're a particularly vulnerable population to try to transition to an adult GI. And lastly, they have many years or in decades ahead of them with disease, so they really are going to have a really long road ahead of them as well. The second concept is that emerging adulthood is quite turbulent. This is a very vulnerable period to try to transition a patient. However, culturally, pediatrics tend to stop taking care of patients somewhere around end of high school to end of college. And this really does coincide with a relatively turbulent time period. Because of this vulnerable stage of development, there is a lot of evidence to suggest increased risk of disease progression during this time period, an increased risk of medical complications. We also know that compared to all of the different types of adults out there, emerging adults utilize emergency room services at the highest rate. And lastly, we know that they have a disproportionately high burden of healthcare costs because they are such a vulnerable population. The last concept is there's really a lot of good evidence to suggest that as pediatric gastroenterologists, we historically have underprepared our teens for being managed by adult GI providers. Several surveys have shown adult GI colleagues commenting that their population of patients that come to them from pediatrics tend to have a poor understanding of their condition. They also tend to have poor knowledge around the medications that they're using. They have limited self-management skills. They tend to come from institutions that do not have a written transition policy. And there's definitely a perception gap between adult and pediatric GIs regarding what types of competencies are needed for a successful transition. So taken together, it suggests that if we have patients that are particularly needy and particularly vulnerable and tend to have worsening disease, that they really ought to have a comprehensive transition of care. So let's just briefly talk about what is a transition of care. Transition is a purposeful, planned movement from pediatric care to adult care, where we move not just the patient, we also move all of their records, and it's done in an orderly fashion. Transition of care is not just a transfer of records and management from one provider to another. It's a process. It's not an event. So we tend to think about transition as really a long period of time, potentially beginning as early as age 12. Really, from a 30,000 foot view, the major goals are to get the patient ready for transfer, to get the parents ready for transfer, and to get the adult GI provider up to speed. We're going to get into some more detail on that in a second. And really the reason to do this is we want to promote self-reliance in our patients. We want them to become independent, and we really want to empower them. Even though they are just emerging adults, we want to feel like we've empowered them to take control over their own care. And we accomplish this through a variety of ways. The most important concept is to have regular and repeated discussions over many years with the patient and their family. There are some formal transition readiness tools that we'll talk about in a few minutes. There's a really important concept around seeing the patient independently. And over time, the pediatric provider should be spending more and more time independently with the patient in order to really feel like there's a sense of responsibility. And we're trying to make sure that they're able to advocate for their own needs without their parents right in front of them. And lastly, some of this is around shopping for an adult GI provider that we think will, A, understand this transition process, but also will be a good fit for the patient. So in a little bit more detail, we start the conversation very early, around age 12, and we're always educating the patient, and we're always assessing for their preparedness for the adult GI experience. And like I said, there are some checklists and tools that can sort of help create an objective sense around what needs to be accomplished. But really, this is about that lasting relationship between the pediatrician and their patient. Really make sure that they've assessed for readiness. So, first of all, is this patient even in a state of disease quiescence? Are they in remission? Or are we really working hard to get disease under control? Because if we're really working hard to get disease under control, it's definitely not the time to really get to the late stages of transition. If the disease is in a state of quiescence, another important question to ask is whether the patient has a good understanding of their disease. If not, then it suggests that we need more time educating before getting ready for transition. There's a concept around self-efficacy. Has a patient demonstrated self-efficacy? And self-efficacy is the concept around patients feeling like they have the power to create their own destiny, to make a difference in their own disease. For example, if we have a patient who is smoking and we explain to them the role of nicotine in making Crohn's disease worse, does this patient believe that they have what they need to begin a smoking cessation program? Do they believe in themselves? Do they understand the idea that if they work hard at this and get nicotine out of their life, that it will make their inflammatory bowel disease get better? So the concept of self-efficacy is important to assess before transitioning a patient to the adult GI community. And then in the background, making sure that we have a patient in a stable social situation. And this is obviously a little bit of a dicey call because most patients between the ages of 18 to 25, by definition, are not super stable. They're either in transition to school or a job. Some don't have a source of income and don't have a trajectory. And so a lot of this is really just assessing what their future looks like. And that's, again, a conversation that's had over a long period of time. So at the end of the day, we really want patients to be able to express out loud what illness they have, what parts of their body are affected, who their doctor is, what types of medications they're on, what the doses of the medications are, what the frequency of the medications are, what allergies they have, what side effects they have, and also what are they looking for in terms of care and what their needs are. So if I was to sort of summarize the 6 really important concepts that we really want patients to nail before transitioning to an adult GI doctor, One is problem solving. Are they able to see a series of steps that they need to do to get help for something? For example, they're leaving on a trip to go study abroad uh, in Europe, and they're trying to figure out the timing of when to take their Humira shot. And so, are they able to work through when their plane is, when they're going to arrive, and where that shot might fit into their schedule? Number two is knowledge. Do they know their disease location? Do they understand the mechanism of action in a broad way of the medications that they're using? Self management is, are they able to take care of themselves? Are they able to practice good hygiene? Are they able to do their shots by themselves? Are they able to count their pills? Are they able to call up the pharmacy if they run out of medication? Decision making is when we come to a crossroads in medical care, when we're trying to potentially make a change in therapy, and we give them risks and benefits for potential options. Are they able to weigh those risks and benefits and make an informed decision for what they're looking for? Self advocacy, are they able to stand up for what they need? For example, if I have a patient on a medication that is causing some toxicity, but I believe they're doing okay, are they able to say, hey, Dr. Essers, this methotrexate is making me nauseous. I'm done with this medication. We gotta find something else for me. Or, hey, I'm starting my freshman year at college, and I really feel like I need some additional resources. I need privileges for untimed testing, or I need a different type of dormitory that's going to give me the type of meal plan that I need to take care of my disease. And lastly, self-efficacy, which we talked about, is, do patients feel a sense of empowerment to do what they need to do to take care of their bodies? At the end of the day, even though that is a very dense set of skills, these are supposed to be stressless, seamless, and structured over many years. So these things don't happen overnight. And again, this is a longitudinal assessment over a long period of time. I mentioned some transition readiness tools. I'm just going to briefly mention a few. One is the TRAC, the Transition Readiness Assessment Questionnaire, which, if you're looking for a sort of a numerical way to get a sense of whether your patient is ready, you can look at the TRAC. Toronto Sick Kids developed a passport, a My Health passport, which is a small wallet-sized card, which basically is like a crib sheet for the important features of your disease. Where is my disease? When was I diagnosed? What are my medications? What procedures have I had? What surgeries have I had? Lori Fishman at Boston Children's put together a transition readiness checklist, which is just a good, think about any checklist that you might have, your grocery shopping list. Did you get everything you need? This is sort of like a checklist that you can go through to make sure that you've sort of checked all the boxes around skill sets that your patient should have before transition. And then lastly, there is a IBD self-efficacy scale specifically for adolescents and young adults, which is a good tool to specifically assess self-efficacy. Toronto Sick Kids also developed this really great short skill called the My Health 3-sentence summary, which I really love. And it's basically supposed to give the emerging adult a framework on how to really rapidly convey the most important information to a provider when it matters. So sentence 1 is age, diagnosis, and brief history. Sentence 2 is my treatment plan. And sentence 3 is what are my concerns and what are we talking about? So for example, hi, my name is Sally. I'm 16. I have Crohn's of my ileum and stomach. I've been hospitalized twice, but not in the last 5 years. I'm on Remicade since I was 3. I'm here today because I've lost 5 pounds and I have blood in my stool. When I hear my emerging adults start to speak that sort of language, that's when I know that they're starting to really wrap their head around communicating with physicians. And in pediatrics, we'll get into this in a second, but in pediatrics, we spend a lot of time with families and patients, and we hold their hands, and we really help sort of massage out and milk out the information from families and spoon feed them in a lot of ways. And we're looking for them to be able um, to eventually spit out this information almost unprompted. And I just love this paradigm because it's just so short and easy to follow. A really nice tool that was sponsored by providers at Cincinnati Children's and Nationwide Children's was the Inflammatory Bowel Disease Self-Management Handbook for patients and families with IBD. This is a really good resource. It's been around for a long time. Still, though, a really good resource to sort of give you the three-dimensional look on all the things that go into preparing a child for adolescence and for adulthood and for that transition. So I encourage you to take a look at that guide. So one of the things that holds us back from making a good transition, and this is not an exhaustive list, but some things that I think are really important, is to the point of the many peer-reviewed articles that suggest that our patients still really don't have a fund of knowledge, is that when patients don't have knowledge, they don't ask questions. They don't know how to advocate for themselves. Another thing that holds us back is a lack of self-efficacy, and this is something that you can't just implant self-efficacy into a patient. It's something that happens over time. But if you don't feel empowered, if you don't feel like your hard work is going to pay off in terms of your health, how are you ever going to advocate for yourself? Pick up the phone, call your doctor, be proactive about your care. There's also a lot of reluctance from the between the pediatric provider and the patient. The patient is often sluggish to make a transition plan. The pediatric doctor gets busy and doesn't necessarily feel a lot of buy-in from a patient. So we hear this a lot from families, that they just feel like they never really got a transition plan. There's also a lot of reluctance from the families to seek out an adult GI doc, and a lot of that has to do with the fact that they feel very comfortable with the pediatric care. And lastly, one big barrier is organizational obstacles. So putting together a transition program really requires policies, it requires funding, it requires time from providers, and these are things that are very short in supply in large institutions. So solutions for these things, as we discussed, there are apps and tools for helping families understand, and literature and books to help families understand about disease. It's also incumbent on the pediatric providers to be teaching their patients. Lack of self-efficacy can be combated with independent visits with the provider by encouraging young adults to start calling the office independently. And I love MyChart for that. MyChart is the HIPAA compliant secure app for communicating with providers, for asking for prescription refills, for checking labs. And when my patients turn 18, I really require that they get on MyChart so that they stop having their parents provide all of the resources for them. Reluctance between all the parties is really combated mostly by ongoing communication over long periods of time and making the process slow but steady. And also reviewing transition readiness tools as appropriate. And then, for organizational obstacles, it's really challenging. This is going to require systematic changes in advocacy, both at the regional, state, and national level. It's going to often require additional funding, which every institution has their own set of struggles around. Just a few kind of blurbs, summary blurbs on how we hear the way patients talk about transitioning. I'll have patients say some version of, pediatrics, they're just so attentive. You don't have to go out of your way. They just tell you everything you need. They spoon feed you. And this is the doctor that diagnosed me. They're kind of like the parent of my illness. They know everything about me. How am I supposed to transition over to an adult doctor? I hear parents say things like, they often feel concerned for their child because the pediatric team cares so much, and they just know in the adult world that the adult GI doctors are not going to be calling at your house to find out why you missed your appointments. They're not going to just show up on your doorstep and say you need to be there at your appointment. If you don't show up, that's on you, and that's very anxiety provoking for parents. Um, and there's also this dichotomy of, I want them to grow up and I want them to assume responsibility for their care, but it scares me to let go of that control. Really common concern from parents. And then I hear from, this is a paraphrase, of course, but I hear from adult GI doctors some version of, look, we're very busy here and, we have to meet our bottom line and we have to generate revenue. And we can't provide the type of concierge level service that pediatrics provides. It's just not practical. And, pediatric patients, really, they show up in our practice. They don't even know the number to call us. They don't know how to schedule their appointments. They have their parents call. The mom figures out what to do for them. And that's just not going to work in my clinic. And so this is a really good kind of summary about the major differences between child-centered care and adult-centered care. And in child-centered care, it's friendly, it's familiar, parents are involved, the visits are longer. In adults, it's short visits. It's a lot more patients. Patients are a lot sicker, and it often can feel a lot more business-like. The focus in child-centered care is nutrition, growth, puberty, psychosocial milestones. And in adults, it really focuses a lot on survivability and sustainability. So malignancy, cancer surveillance, treatment side effects, pregnancy, getting to old age. The goals are different. And, in pediatrics, we're really focused on limiting radiation, limiting steroids, making sure that we're clearing the way for growth. And in adult-centered care, of course, they want to minimize any untoward side effects, but their focus is really around managing lots of chronic conditions together and managing a lifetime of complications that have all caught up with the patient. The team in pediatrics tends to be really multidisciplinary. There's social work, there's dietitians, there's pediatricians, there's often endocrinologists. There tends to be a bigger team. Whereas in adult-centered care, you can have a big team, but it tends to be more like a single doctor managing your disease. If you get admitted, you have this special pediatric wing to the hospital where you're at, where everything around you is peds friendly. Once you get to the adult population, you're in a general hospital, potentially on a general ward with sort of all ages. The endoscopic sedation tends to be a little bit different. We use really deep sedation in children, so there's really absolutely zero memory of the experience. You're completely unconscious. And in adults, it tends to be more moderate sedation, so still friendly, still not painful, but maybe a little bit more memory of the experience. There tends to be also a lot more procedures because of cancer surveillance. And lastly, the social piece is different. In pediatrics, we're dealing with school and stress and boyfriends and girlfriends and drugs and alcohol. In the adult population, it's around family planning, cessation of smoking, long-term psychological effects. And so really, we're trying to find this great balance where, at the end of the day, you're still getting everything you need, but as you transition from peds to adults, really that focus really starts to shift from growth, your family-oriented experience and nurturing, to privacy, prevention, autonomy, and longevity. Just to summarize a couple other things here for you is that at the end of the day, change is really good. It's great to see children grow up into emerging adults and then into full-fledged adults. Transition is necessary. You have to make that transition at some point. However, nothing really succeeds if it's rushed. And if we prepare in advance and we make this a longitudinal, reiterative experience, it's going to be a lot smoother. We want to encourage our patients and our families to ask lots of questions, to use apps and other readiness tools as appropriate, and to also follow the literature because this field is still very much evolving. Speaking of which, the last position statement from the pediatric GI community was back in 2002. We're probably due for an upgrade soon, but I encourage you to check out uh, the medical position paper in the Journal of Pediatric Gastroenterology and Nutrition in 2002. Thank you very much for your time. Sorry that we can't be there in person with you guys this year. We very much look forward to these educational conferences, and I will be on a live call to go over this presentation with you guys, as well as with my colleague, Dr. Carly Osk, who I will now pass the baton over for a little bit more of an in-depth discussion on the adult GI perspective. Thank you very much.